Phyllis. And it's a pleasure to be here. Thank you for sticking with us today as we head into the late afternoon here. And it's a real pleasure to speak with the committee today about what we're learning from doing this multi-sector collaboration at a community level, working with the communities that we serve, and also with some of our national partners. And I just have to make an observation as I start that we have come such a long way in the last 5 years, 7 years, and I think it's a credit to many of you that are on this panel that we're at this point where we're talking about the practice now and not the basic idea. We're not trying to sell the idea. We're really working on the practice. So I wanted to start off by talking about what the issues are that we're finding in a round of community health needs assessments that we're just wrapping up now. As an organization, I should say that we're, many of you know, we're an integrated delivery system. We've got 37 hospitals, 9 million members. We've got a health plan function. And as part of our hospital function, we're required to do community health needs assessments. Some of the top issues that are coming up across our communities speak to the importance of doing multi-sector work and the fact that we can't address the health burdens that our communities are facing with the limited tools that hospitals and doctors and the medical system have. So in healthy eating and active living and related obesity, diabetes, we see the issues of safety and physical activity environments as a major issue. Violence is an overarching issue in our communities, and people talk about toxic stress and the impacts on parenting, the social service system, which doesn't serve them. And then way upstream, we heard a bunch about economic security, the burden that poverty and the recession have created, and low-wage jobs, and the challenges of eking out an existence, and the messy desk, the messy real desk of people's lives, where meeting basic needs pushes away access and some of these other issues. So we are grappling with these issues in a big way, and we know that we need to have partners in order to address these issues. So I just wanted to root us in what the communities are telling us their basic, most fundamental community health needs are. I wanted to give you some examples now from some of the work that we're doing addressing community health needs with our community partners. I wanted to start off with some overarching insights, observations, maybe a little bit of opinion from doing this work. And I think these are going to reinforce things that we've heard all day. The first and probably the most important point is that we're learning that we need to be focused on convergent strategies, even if the goals of the organizations that we're collaborating with are divergent. So divergent goals and missions, convergent strategies. What we're learning about this work is that it's not about getting everybody else to adopt your platform or your mission or your goals. It's really about finding what's in the nexus of our interests and not trying to convince each other to change their basic purpose. The reason that's so important, I think we heard about it from the panel before, and actually our first panel too, is that the goal here is to harness the expertise, the passion, the interests that these different groups have that come at these issues. And you don't do that when you try and get everybody to sign on to the same platform or the same mission always. It's a little bit more opportunistic. So that is a big learning for us. Relatedly, there's this notion about co-benefits as a frame, a communications frame, and an organizing principle, very related to the first point. But the idea here, especially for those of us who care so much about health, is that we have to leave our health language and principles at the door and go out to meet these other groups on their terrain, learn their language, their priorities. The panel that preceded this one was very articulate about this, about the need to understand the hidden interests sometimes, what's really motivating these other groups and the professional vocabulary of theirs. That's very much a part of this co-benefits thinking. We are learning that it's a very unusual kind of partnership structure and technology that's required to do this co-benefits work. We really need to find organizations, whether they're backbone organizations or intermediaries or site coordinators, lots of different kinds of roles here. But it's a unique kind of skill and capacity to shuttle between these different expert groups and not impose a particular content area. And it's really qualities of being a good host, a gracious dinner party host, setting a table that everybody feels comfortable scooching their chair up to, which is really important. And then finally, we need to be flexible and take opportunities where we find them. So let me illustrate these insights with a couple of examples. The Valley High Heal Zone, Healthy Eating, Active Living Zone, is one of 40 community health initiatives that Kaiser Permanente and some of our funding partners have launched across the country now. Some are 7-8 years into formation. This one got started just last year, and like many of the community health initiatives that we're working on, the focus is around changing food and physical activity environments to really drive behavior change of a small geographic population. There's a bunch of partners that gathered around the table to develop that plan and implement it. And some early priorities that Valley High Heal Zone identified were around community safety and walkability around this park that's in the middle of this map here that were seen as barriers to behavior change. About 6 months into the planning process, there was a walkability audit that was happening at this park. There was a shooting at that park while they were doing the walkability assessment. Totally changed the energy in the collaborative. Safety was always an issue, but in that one afternoon, the energy completely shifted. The police department, the church across the street got engaged in a much more robust way, and the community prioritized gang violence and safety. They took back the park. They put a ton of energy into community building strategies, bringing people out onto the street, and it really changed the priorities, and I think in a really good way, because what happened is they ended up, this is a picture of Valley High Park after the work. The community really did take back the park. They created a basketball league that brought a lot of activity to the park, other activities, and while it might sound like a trifling example, the real power of this is that it built community cohesion, people knew each other, and people were engaged in a very visceral, real way. Even though the initiative started off as focusing on healthy eating, active living, what galvanized this community, given what happened, was something much more eminent. It was around safety, it was about quality of life, it was people worried about their kids getting shot when they walked outside of the house. And this is a real tension that we've seen in all of our healthy eating, active living work. Many of our communities, I say more than half of them, have identified violence as a big issue. As a healthcare organization, we're really care about the behavior change outcomes of this, and we have to hold this tension between focusing on significant strategies to improve behavior, address behavior change on one hand, and meeting the community where they are. So that was a big lesson for this work. I'm not going to talk about the Thriving Schools work we've done because Rochelle covered it really well. Just to say that as an organization, we looked around and realized that 1 out of every 5 of our 9 million Kaiser Permanente members spends most of their day in school, either as a school-age kid or as a teacher or a staff member. So we are focusing on schools in a big way, and Rochelle did a great job talking about the mindset that we need to have when we work in schools, not going in with a health focus, going in focusing on the issues that schools care most about. Another example that I wanted to talk about now, kind of moving up from community level to some of the larger scale changes that we're working around, is the Everybody Walk work that is emerging here. Everybody Walk includes a collaborative that includes a bunch of partners that care about walking and walkability. It includes the Surgeon General's call to action on walking, which is going to be released in May of 2014. There's some social media stuff, and there's a walking summit that's planned for October 1st. So if anybody prays here, pray that there's a budget resolution so that we don't have to deal with the craziness on October 1st if there's a shutdown. But the point here is that we're thinking about how it is that we can build a movement for walking and walkability. And this work started off with some incredible enthusiasm from our former CEO, George Halverson, around the health benefits of walking. And as we took his gauntlet that he threw down and really developed the movement, we realized we really had to have this co-benefits approach here. And so what we've done is we've brought together partners that have very different goals. So the developers that are part of the Everybody Walk Coalition, think about it as a business development strategy. One of the developers that we're working with says that pedestrians are an indicator species of a vibrant downtown. So we're talking about economic development for the developers. The National PTA is involved. They care about health, but what they really care about is kids walking and biking to school. They see it as a quality time between parents and their kids. You go down the list. The National Park and Rec Association and the National Park Service cares about it because they see this as a constituency building for the parks. So we really have to have this kind of broad perspective around engaging constituencies, doing constituency building, and that means not leading with health all the time. I wanted to wrap up with a conversation about the Convergence Partnership, which is an effort that includes many national funders. The CDC is a technical advisor. It also includes many of the organizations that are represented by IOM, by the committee's membership here. And we started the Convergence Partnership many years ago with a vision of improving food and physical activity environments and community health, but doing that in a really broad way, putting equity in the middle of it, thinking about policy and systems change, but importantly, this last thing, connections, creating a field of fields that allows people to work together more effectively in this co-benefits kind of way. And that has been a touchstone for us, and I think we've achieved some really fabulous results. I'm not going to go over them, but we've had some incredible successes at a federal policy level, including some of the things you've heard about today about the Sustainable Communities Partnership, many of the grant programs that come out of the Prevention and Trust from the Affordable Care Act, and the Healthy Food Financing Initiative. All these things were driven by this notion that we need to work at the nexus, and the Healthy Food Financing Initiative being a great example where coming out of the Pennsylvania experience and trying to scale that up, that didn't start off as a health thing. It started off as a jobs thing, a social justice thing, and so we have found really great resonance with that approach on the federal policy front. But perhaps more importantly, on a field building, in a field building way, we have seen this mushrooming of this idea with now about 25 states that have a regional convergence partnership of multiple funders that are working together in this way, or innovations fund grantees that are funding in the nexus of health, sustainability, social justice, economic development, some of these other things. And this will give you a flavor for how diverse this movement now is. And so we're really seeing this groundswell of success here and a ton of engagement on the field. I think we're changing the way philanthropy thinks about this, and we're creating a very wonderful opportunity here. I want to conclude with some kind of big factors of success that we've seen in this. First of all, a disciplined focus on the value proposition, and that is to really focus on these co-benefits. There are a number of big policy issues that we didn't take on, the Child Nutrition Reauthorization Act being one of them, because there was other people in the field, or it wasn't kind of sufficiently a co-benefits kind of thing. We've really tried to make space for enlisting new partners. The partnership structure and operating agreements really matter. Creating the trust, understanding what each other's different interests and benefits of engaging were, and really importantly, the role of a backbone organization that could hold that space, do the right table setting. We've been very lucky to have Policy Link as the project program director, and the Prevention Institute that's held that space. Finally, just bringing it back home to Kaiser Permanente, we think of the framework that we use to hold all of this work, the community work, the national partnership work, our broader prevention strategy as this total health strategy. And the idea here is that we know, as has been said many times today, that the healthcare system is the small lever for driving population health, and we know we have to work outside of the medical office building to seize the levers of health. We've got a lot of assets, a lot of impressive assets that we have at our disposal within our own organization to drive that, but we know we have to engage partners to do this work. And the last point here is that we really think of this as health in all Kaiser Permanente policies. It's not just our doctors and our prevention folks and our community benefit apparatus that's important. It's our procurement and supply operation, our ability to create healthy food in our cafeterias and the communities that we serve. It's our $1 billion supplier diversity initiative to address the sources of health that reside in vibrant local economies, and the ability for us to move our dollars around so that we could play a big role there. So we're really trying to think about the full panoply of assets that we have, and I think that it's been informed by health in all policies kind of thinking. We're applying it to our own organization. So with that, I think I will stop and look forward to the conversation to follow. Thank you.
Thank you, Lowell. So next we have a team that's from California with the idea that they're going to share with us some of the experiences that they've learned and some of the lessons they've learned through the Strategic Growth Council Health and All Policies Task Force. First speaker is Linda Rudolph, who was previously with the California Department of Public Health and chaired the Health and All Policies Task Force. She is now co-director of the Climate Change and Public Health Project, Center for Climate Change and Public Health at the Public Health Institute.